the first thing we're going to talk about in pathology is abnormal perfusion and function. We're going to talk about intracranial hemorrhages. So anytime there's a bleed in the head, it's called intracranial hemorrhages, and there are different types. It's the most common cause of neurological morbidity and mortality in the newborn. Most intracranial hemorrhages occur in the first 3 days of life. They can occur in utero, but it is not that common. And most of these intracranial hemorrhages are due to hypoxic ischemia events. Oxygen gets cut off and you get ischemia. You can read over all the clinical symptoms. More commonly, remember, preemies less than 32 weeks and less than 1,200 grams birth rate more commonly are subjected to intracranial hemorrhages. And you can read over the list. Also, some other risk factors, small for gestational age, maternal preeclampsia, if the mother develops preeclampsia during her pregnancy, asphyxia, antepartum hemorrhages, and male neonates are more prone to intracranial hemorrhages than females. When you have a baby that has an intracranial hemorrhage, you should do follow-up ultrasounds every 5 to 7 days. That is what published literature says. We all know that. Sometimes we do them sooner. And of course, if their condition warrants something happens, we're going to do it sooner also. Your most severe hemorrhages are associated with hydro or IPH intraparenchymal hemorrhages. That's when we're going to talk about that. That's when the parenchyma starts to bleed, and these occur within the first 24 hours of life. But most of your intracranial hemorrhages in preemies occur in the germinal matrix, caudate nucleus, cerebellum, and choroid plexus. So remember, when we talk about hemorrhages, any type of bleed in ultrasound, any type of bleed, right? Any type of bleed, it changes its sonographic appearance depending on its age, right? Okay. So acutely, these hemorrhages are increased in echogenicity. Then within a week to 2 weeks, they become more echogenic, and they start to break down, and you get a central sonolucency. From 2 weeks to 2 months, you'll still see some clot and retracting hematoma. And between 2 to 6 months, you might see just a total sonolucity, big cystic structure, especially if it's an IPH. So we're going to talk about the different types of hemorrhages before we go on our next break. A subependymal germinal matrix hemorrhage. Subependymal germinal matrix, same thing, okay? This is a germinal matrix hemorrhage coronally. This is a germinal matrix hemorrhage right here. Now look, 31 weeks, okay? Germinal matrix hemorrhages are the most common type of hemorrhages in preemies, more common in infants less than 32 weeks, and they weigh less than 1,200 grams at birth. And it's very unusual, remember, to see a germinal matrix after 34 weeks gestation. Remember that the germinal matrix matures in the perinatal period. So half of germinal matrix hemorrhages in preemies occur in the first day of life, and they correlate very well with extreme prematurity and birth asphyxia, because what's the last thing to develop in babies? Their lungs, right? So they all have problems breathing. The germinal matrix area is the most common site of a subependymal germinal matrix hemorrhage because of the fragile capillaries. Now, it is believed that preemies lack the ability to auto-regulate the blood flow in their brain. So the fluctuations can cause the germinal matrix vessels to rupture and they can get infarcts. Also, subependymal hemorrhages can progress to intraventricular and intraparenchymal hemorrhages. So remember where the germinal matrix area lies. Here's your caudate nucleus. Here's your thalamus. That's the caudothalamic notch, right? And they can extend all the way around this way, okay? They rarely go down to this area. The most common site is at the junction of the caudate and the choroid, right in here, right? If it extends beyond the lateral edge of the frontal horn, it's considered an IPH. What do I mean by that? I'm going to go back. So say the baby starts having a germinal matrix hemorrhage here and extends all the way in front of the frontal horn. Well, then it's in the parenchyma and it would be called an intraparenchymal hemorrhage. They can be unibilateral and asymmetric, okay? And you see an echogenic lesion, you may see a bulging into the ventricle, which you see right here, okay? And then here are two bilateral, one's small, one's larger. Remember, the normal choroid is very echogenic, so you must take care in identifying a subependymal germinal matrix hemorrhage. You must have the whole ventricle in view with the choroid in the ventricle.